Welcome to ChalkWalks. Okay, in this case we're going to talk about a 10-year-old male castrated domestic short-hair cat, a little less than 4 kilograms. And he's slightly on the lean side. He was diagnosed with diabetes mellitus 2 years ago and basically hadn't been monitored, no follow-up blood work since then, which is pretty amazing. And according to the owners, has been stable on 2 units of humulin N along an intermediate acting depot preparation of insulin. It's basically human recombinant NPH insulin every 12 hours. Now, the question might be, how could this cat possibly have been this stable? And it may have been that amount of insulin, not an unusual amount for a cat this size, might have been adequate for most of the circumstances. And the cat may also have had some residual insulin secretion. Remember, cats are more commonly going to have, as their etiology, and at least initially, a type 2 diabetes, which means they may have some residual amount of beta cell function. But that doesn't mean they don't need insulin. That means, in fact, this was appropriately treated. In most cases, other forms of therapy to reduce glucose, oral hypoglycemic agents, generally are not effective over the long term in cats. So recently, in the last 2 days, in fact, so we have now the history of 2 days ago, stopped eating and became lethargic, and the owners stopped the insulin. Now, this is depending on what the owners had been told. Of course, if they're not monitoring this cat with blood glucoses periodically, they may have forgotten what they were told. But that amount of insulin that you give during the periods when an animal is eating should not ever be stopped. It could be reduced. If an animal goes anorectic, you can usually give 1/2 the dose. Or you should really train your clients to call you when that happens. So in addition, and consistent with the glucose going up, there has been increased drinking over the last 2 days. And when you examine the animal, it's depressed and has an 8% dehydration. A CBC shows basically a left shift with neutrophils and bands being elevated and a reduced lymphocyte count. Urinalysis shows most notably glucosuria, ketonuria. And when you see ketones in an animal, particularly one that you know has been diabetic, you can assume that the amount of insulin that it's been getting, of course now we know in the last 2 days it has had none, is inadequate. Because the first thing that happens is that we start to see lipolysis, and the lipolysis is due to the lack of insulin action, and the lack of suppression of lipolysis. So these then, the fatty acids then are converted through the mitochondria to ketone bodies in order for the brain to use them for energy. Consistent with the fact that this cat was not well managed, we have fructosamine being elevated. The normal range, reference range, is no more than 400. And fructosamine in monitoring a diabetic is useful for chronic assessment of, say, the last 3 weeks or so. So roughly around 3 weeks, that's based on the half-life of albumin in the bloodstream. You can, if you see an elevation, you're going to give you an idea of how well this animal was managed, and it's clearly not managed. Now, you generally keep note of that, not so much for a diagnosis, except in the case of possibly seeing stress hyperglycemia, which this isn't the case, but rather as a baseline. So this 783 is going to be our baseline if we want to follow insulin therapy. And that's the most valuable aspect of measuring fructosamine is say for that animal, let's see what happens as we start to improve our insulin, attention to our insulin therapy. In addition, this cat had evidence of pancreatitis, and what evidence is that? We have two things here. We have an abnormal ultrasound that suggested pancreatitis, and also increased feline pancreatic lipase immunoreactivity. This test was abnormal or elevated. In addition, there's some free fluid in the abdomen, and at that time it was decided to go ahead and take a needle biopsy of the liver, which showed lipidosis. And this is something that you have great concern over in an animal, not only with a diabetic, but also in the situation where you have an animal that stops eating. Hepatic lipidosis is generally a concern in cats when they fast, and can develop, for reasons still not very clear, great deposition of fat within the liver, and this can lead to overt liver failure. And indeed, in this case, the animal had elevated bilirubin at that time, and also increased liver enzymes. Okay, let's take a look at the biochemistries in this cat, and we're going to focus initially on day 1, and we're going to use this graph throughout the initial treatment period. But the first thing that you see is the cat is quite acidotic, and with a total CO2 of 4, it's got a metabolic acidosis, and that's expected with diabetic ketoacidosis. The cat has a low sodium. It has a borderline potassium, and you know that, at least you should know, that as you add insulin, that will lead to the moving of potassium into cells, so we can expect that the potassium will fall even more with acidosis being corrected and with insulin. And that's due to the stimulation of sodium-potassium ATPase. So the initial treatment, and let's just keep going on before I go to treatment, the glucose is 605, and the cat this was the period where it was 8% dehydrated, so it's not unexpected to find a mild elevation of BUN and creatinine, even if the kidneys are functioning quite well. And you can see later on, after fluid therapy, that creatinine does come down. I also want to focus on the deficiencies, not only in potassium or impending potassium deficiency, because the potassium in the plasma is just sort of the tip of the iceberg. Anytime you get a low potassium in the plasma, you probably have 20 to 30% deficiency within the intracellular space. Is that around magnesium and phosphorus. And these are intracellular cation and anion, respectively, that also tend to be depleted. Now, phosphate's a little elevated here, but you can see that as the animal becomes treated, it becomes deficient later on. We'll talk about that later. So the initial treatment was to give a 50 milliliter bolus twice, and these calculate up to around each 25% of the maximum rate of around 80 milliliters per kilogram, given twice, because the cat was so depressed and the sodium, it turned out, was low. And so then it was followed by the use of plasma light. Plasma light is basically like plasma itself, as you expected, and compared to, say, lactated ringers and, say, acetated ringers or Normasol R, it has additional magnesium, and it has acetate and gluconate, which through metabolism will become bicarbonate equivalents. It's an isosmotic or isotonic solution, where the normal tonicity being 280 to 310 milliosmoles per liter. In addition to the roughly 5 milliequivalents per liter of potassium that's in this solution, there were 20 that were added, and that was just in anticipation of starting fluid therapy. And that really was all that was done on day one, is fluid therapy was initiated. And you can see just that alone led to a rise in sodium. It didn't do much for the potassium. It was sort of holding its own, but chloride went up, and you started to see the deficiencies of magnesium and phosphate become evident. But glucose will fall as you improve renal function and you get greater glucoseuria without even starting insulin treatment. And so the plan was to use this approach, 32 milliliters per hour for 12 hours, which was basically maintenance plus the calculated dehydration being replaced in the first 12 hours and then backed off after that. And then in addition, because of the left shift, they added ampicillin sulbactam, a potentiated penicillin, given every 6 hours, IV. In the morning, insulin, regular insulin, and this is the backbone of treatment of diabetic ketoacidosis, is a constant rate infusion, or can be given sub-Q or IM. Usually constant rate infusion is used, or IM hourly is the most typical way that if you don't have an insulin pump or a pump to use, you can give it IM and then follow every 2 hours, Q2Rs monitoring of glucose. And that was basically what was done. So you can see that on day 2, compared to day 3, we start to see a reduction of glucose. We start to see greater improvements, some evidence that we've replaced the fluids and the pre-renal azotemia has gone down. Sodium is still normal. Now we're uncovering that even the 20 milliequivalents per liter is not enough to hold potassium up. And so 2.9 is now actually below the normal range, just like we predicted. Insulin is going to drive the potassium into the cell. And so because of that, potassium was then increased to a total of about 40 milliequivalents per liter. And as you can see, we were uncovering a magnesium and phosphate deficiency. I won't go into the specifics of how much, but we're adding concentrated phosphate, sodium phosphate, and magnesium sulfate. And they upped the fluid rate to 95 milliliters per kilogram per day. Now let's take a look at what happened on day 3. On day 3 was basically the cat had a nasogastric tube placed. There was concern about it not eating and also the lipidosis, and so feeding was initiated in that manner, and it was basically treated with oral calf electrolytes and also what's called emerald feeding solution. Because the potassium had started to fall and was detected as falling in the morning, they increased the potassium to basically the total of almost 80 milliequivalents per liter, actually 79 to be exact. And this is a fairly aggressive amount of fluid therapy. You do need to do the calculation. At this rate, which is now at maintenance rate, 80 milliequivalents per liter is just fine, but I think it's worth going through the calculation, making sure you do not go greater than 0.5 milliequivalents per kilogram per hour, because that can kill an animal. In addition, because of the concerns for the liver, and now what was evolving was, you'll see, an anemia, we're seeing some additional treatments come on board. They included vitamin K subcutaneously and arginine. And arginine is converted to nitric oxide, and also therefore has effect as an antioxidant. On day 4 and 5, because this aggressive potassium therapy seemed to be successful, or started to be successful, although I'm not really sure. It seemed that they started it here, went up to 3.2, and then it stayed at 2.9, and they, for some reason, dropped it back down to 40 milliequivalents per liter. You can see that it didn't take until day 5, 6, and beyond to get it back close to the normal range. And what happened on day 5 is very interesting. And insulin is being continued in the amount that basically what they were giving were 8 units of regular insulin per 250 milliliters of saline, 0.9% saline, as I showed on the previous slide. And they were adjusting this, concentration, the amount that they'd give in the fluids, anywhere between a rate of usually 10 mils per hour. And sometimes they would double that concentration and go back down to 5 mils per hour. But they were giving more or less the same amount of insulin, which was 1.1 units per kilogram per day as a constant rate infusion. On day 5, they noticed, and they initially, the cat's hematocrit was 44%, and it dropped to 17. Initially, they thought this was just due to the excessive amount of blood being drawn. However, they also noticed Heinz bodies, and this suggests that there's some oxidative event occurring, and this led to the addition of some additional therapies. Carnitine was added, Denamarin, I didn't add that here, Denamarin was added as an antioxidant. And they had done a gastroscopy and biopsy by that point and found erosions. And for those, this was in the stomach. They felt like this cat had ulcers. That could have been the source of some of the bleeding, and so they added sucralfate, which basically is going to bind to the ulcers and is going to create some healing property for it, and pantoprazole, which is a gastric acid proton pump inhibitor, and these two should be staggered, or sucralfate should be staggered with other drugs, because they were concerned now that the cat would, they had to pull the nasogastric tube. They wanted to get the cat to eat again, so they put it on an antiemetic, the NK1 antagonist, meropetam, and buprenorphine because of the pain and the procedures that they had to undertake. Okay, let's focus on the period of time in which the animal becomes a little bit more stable. And remember, this cat had been on 1.1 units of insulin per kilogram, that is, of regular insulin, up through basically day 6. Okay, and so during this period of time, and here's the glucose. And you can see that by giving a constant rate of insulin, you can have a great chance of getting it down below 300 relatively stably. You can push it even lower. I think they could have been more aggressive, but it's probably not necessary that you do that, as long as the basic thing is that you have resolved the ketoacidosis. And that crucial piece is around having an adequate amount of insulin to suppress lipolysis. So now what? So now you're constantly looking, and they were in this case, for when is the animal going to eat, or in this case, do they have? They put in an esophageal tube, and they planned on sending the animal home with the owners feeding the animal that way. So they switched this animal to 1 unit of glargine insulin every 12 hours. And glargine is basically, it's a mutant recombinant insulin in which the human insulin, in which the terminal amino acids have been replaced by two times arginine. And it has different characteristics because of that. And it's a long-acting or intermediate-acting preparation that is given subcutaneously. And so the plan was to, as you can see down here, to continue that at home with, actually this is an E-tube, not a nasogastric tube, and continue the oral version of potentiated penicillin, Clavamox, sucralfate, and omeprazole, and they added, because of the concern over the liver, and particularly the fatty liver, the choleretic agent ursodiol, which is basically a compound that used to be established from or derived from bear bile, and that's where their name ursodiol comes. And it's used in order to increase bile flow. And so transitioning this animal to a longer acting insulin requires that the animal be fed intermittently. And this is absolutely crucial, why I think in managing this case or others, the use of antiemetics needs to be used carefully, because you really do want to know when is the animal going to eat. Now in this case, they've kind of overcome that with the esophageal tube, and yet I think you still have to recognize that you're not always going to be able to do that in a practice or for an owner or for an animal. So you really would like to withhold or at least be very conservative with your use of antiemetics like meropetam in order to make sure that you can see if the animal is going to eat consistently at home. Because again, we could be back to where we were before. The animal stops eating. You definitely don't want to give insulin. They become hypoglycemic. That's its own disaster. But more commonly, you want to make sure that the animal will eat. And cats are funny because they graze over the day, so you have to sort of almost train them in order to be fed at more frequent and eat essentially in one feeding most of the calories. And so that becomes a matter of finding what the cat really wants to eat. So it's probably most important that not that you have a diet of any particular sort, a diabetes diet, rather something that's palatable for that cat. You need to find that out. As I mentioned, on day 6, the compound denamarin was added because it's an antioxidant that's used for treating liver disease as well, but also is basically a self-hydral donator, and therefore it is an antioxidant. And so that's where we'll leave this case. It's a lot of medicine and biochemistry involved. The case goes on from there, and the cat has additional episodes, but I think this should give you an idea of how you initiate therapy for diabetic ketoacidosis in a cat.